it as soon as we can. Hello, my name is Jessica Tess, and I'm the Social Media and Communications Specialist for the CAPE project. CAPE stands for Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. CAPE is dedicated to identifying and sharing best practices for benchmarking community behavioral health, and is a partnership of the Substance Abuse and Mental Health Services Administration and the USDA National Institute of Food and Agriculture. Today we'll be hosting a webinar called Behavior Change Interventions to Improve the Health of Racial and Ethnic Minority Populations, a toolkit for adaptation approaches. And our webinar speaker today is Dr. Emma Davidson, who is a research fellow at the University of Edinburgh and a fellow of the New Zealand College of Public Health Medicine. As we're going through the webinar, feel free to put any questions you have into the chat box as we go along. I'll be fielding those questions, and we'll also have some time for Q&A at the very end. And just to let you know, this webinar is being recorded, and we will post it to our website, healthbench.info, in the next couple of days in case you know anyone who wants access to this webinar who couldn't attend, or if you yourself would like to access it later. So at this point, I'll hand it over to Dr. Davidson.
Hi, thanks so much, Jessica. That's brilliant. So I'd just like to start by saying thank you very much for inviting me to talk today. I hope you can hear me okay. It's great to have this opportunity just to share this work that we've been doing. I was going to start off just by saying that I was due to be presenting here today with my colleague Jingjing Liu, who's actually based in the University of Toronto. She used to work here with me in Edinburgh, and unfortunately she's been unable to join us at the last minute today, so I just want to send her apologies and also just acknowledge all her work that's gone into this. I'll do my best to represent her today, but there may be questions that come up that might be better directed to Jingjing, and I can always forward those on to her if necessary. I'd also just like to acknowledge our funders that funded our research that we have listed here today, which were the National Institute for Health Research, also the Medical Research Council and NHS Scotland. I'd also like to acknowledge our broader project team. So Jingjing and I were working for a large project team that came from several universities, the University of Edinburgh, De Montfort University, also Newcastle University and Heriot-Watt University, all based within the UK. At the top we can see here our principal investigators, of whom there were 6, and also just below the researchers, including Jingjing, who I'll just point out. Oops. Just pointer right here. So this is Jingjing, who couldn't join us today. So I just want to also thank everyone that was involved in the research and acknowledge their contributions. So I'm talking today about behaviour change interventions to improve the health of racial and ethnic minority populations. I'm going to start today by talking a bit about the terminology and just sort of clarify what terms I'm using within this research. Then I'm going to talk about the background to our research, and then move on to our research study, which was really a multi-methods research and was conducted in 4 phases. So I'll take each phase individually and then talk about the methods and the results of each of them. I'm then going to talk about our toolkit of adaptation approaches, which was the main sort of outcome from our research, and finish with some conclusions and recommendations. Finally, I'm going to just touch briefly on a conference that occurred in the UK last year, just at the end of last year, which was held by the European Public Health Association migrant subsection. And this conference focused specifically on behaviour change interventions for ethnic minority populations. And so I'll just bring out and highlight some of their main findings as well, just to put our research into context. And then at the end, as Jessica says, we have some time for questions. And I think as we go along, you can also address questions in the chat box, so I'm happy to take those too. So I'll just start off a bit touching on the terminology. So as I say, our talk today is about behaviour change interventions to improve the health of racial and ethnic minority populations. And we find there is quite a diversity in the terminology that's used, sort of depending both in where in the world geographically people are based, but also in their sort of research background that they come from, or health organisation that they work for. So in terms of race and ethnicity, these terms are conceptually different, but there is some overlap between them, and they are often used synonymously. And I understand in the United States that this is more often the case. So people often talk about race/ethnicity or racial/ethnic groups. However, in Europe, we tend to favour the term ethnicity, and so this is the term that we've used in our research. Race is seen as historically having more of a sort of biological concept historically, and ethnicity we see as having a more sort of social cultural concept, and so that's why we tend to prefer this term. The definition that we actually used within our study, looking at ethnicity, was where it's referring to a group which people belong to and are perceived to belong to as a result of certain shared characteristics. And these shared characteristics can involve things such as their geography, their ancestral origins, their cultural traditions, or also the languages that they use. So it's really a very sort of multifaceted concept, and also quite a fluid concept that can change between different contexts. So when we wanted to look at developing behaviour change interventions for different ethnic minority groups, we really wanted to take all these different facets into account, incorporate them in what we were looking at. The second piece of terminology that I wanted to talk about was also adaptation. So when we're looking at developing behaviour change interventions for different ethnic minority groups, we wanted to really look at how we could enhance the relevance of these interventions, or enhance their salience to hopefully make them more effective for different groups. And this sort of process is incorporated in different terminology depending on who's undertaking the research. So we found a lot of different terms that are being used. So you may be familiar with terms such as culturally sensitive or culturally adapted or targeted or tailored interventions. So there's a lot of different terms out there, and we found that sometimes this diversity of terminology can actually prevent progress in the field and can make it very difficult to discuss the research that's been undertaken. So for our piece of work, we actually chose to look at, to use the term adaptation and separate this out from the culturally part. So for example, from culturally adapted. The reason for this is we felt that culture is also looked at in different ways. Some people look at ethnicity as being a part of people's cultural mosaic. And some people also look at the opposite. So they look at cultural as being subsumed within ethnicity. So in the definition I gave before, we looked at culture as being a part of ethnicity with a lot of other variables as well. So therefore we decided to use adaptation as it was a more sort of flexible concept, and it considers all the different dimensions of ethnicity that we talked about. We also decided to avoid the terms targeted and tailored because they have quite specific meanings. So work by Matthew Kruter that was done defined these terms, and he talked about targeted as developing interventions particularly for population subgroups with shared characteristics. And then tailoring is something even more specific, where you develop interventions just for one specific individual within a group, and you actually measure their characteristics. So for example, you might actually use a survey to assess different aspects of their characteristics, and then develop your intervention to suit them. So that's very specific to individuals. So we steered clear of these terms as well, and we stuck with adaptation. So I apologise if that's quite a sort of long introduction, but I just thought it made sense to sort of clarify the terms that we've used and that I'll be using in the rest of the presentation. I don't know if there's any questions surrounding these terms, or if I can just move on to our research now. I'm happy to take any questions now if there's anything that comes up. That's great. Well, I'll just move on specifically to our study. So in terms of the background to our study, what we were looking at was that there's really increasing population diversity worldwide just now, with a lot of mix within countries of different ethnic groups. And we find from research that there's substantial variation in health patterns between different ethnic groups. And this particularly is found for long-term conditions, for example, things like heart disease and diabetes. And these are big priorities for public health. Globally, there's really consensus that a preventative approach is very important for these chronic diseases. And so there's a lot of work going into developing programs such as smoking cessation, healthy eating programs to try and deal with chronic disease. However, what we found is there's really little information available about developing these preventative interventions specifically for ethnic minority populations, and this was kind of a gap in the literature that we wanted to address. So what we were thinking about is that there are a lot of evidence already for interventions for the general population for preventative approaches, but we don't really know how effective these are for ethnic minority populations, and this is what we wanted to try and look at. And this is a big concern, because often it is the ethnic minority populations that have the worst health or are suffering more from these conditions in the first place. And if we then put in place interventions which don't reach these populations, we find that our interventions are actually widening the inequalities, and so this has to be avoided. So it's been suggested by a lot of research that adapting these interventions, as I said before, might make them more salient and more acceptable to ethnic minority populations, and thereby hopefully make them more effective. But again, we don't know what evidence there is towards this. It's something that's been widely talked about, but we don't actually know if there's very concrete evidence that the adaptation of these interventions actually does make them more acceptable or more effective. So we were actually commissioned to look into this by the MRC or HTA in the UK. And the actual specific research question that we had was to examine the evidence on preventative health interventions for smoking cessation, healthy eating and physical activity that had been adapted for ethnic minority populations. And the populations we were asked to look at were specifically African, South Asian and Chinese origin populations. And the reason for the choice of these populations was that our funders were specifically interested actually in how this could be applied in the UK context. And these were the populations really that would be most generalisable to the UK setting. In some ways, this was slightly frustrating, we found in the research, because there were other bodies of evidence that would have been very interesting to look at, particularly evidence generated by work with Indigenous populations or the Hispanic population, which I realised would also be very important to the US setting, but we were a bit constrained about what we could look at. So as I mentioned before, our research study was actually in 4 phases. It was a mixed methods research. So I'll talk through these phases. The first one was a summary of recommended interventions for the general population. So this was actually looking at guidelines and systematic reviews, so quite high-level evidence, and trying to find out what sort of acknowledgement or consideration had been taken within this literature for ethnic minority populations. The second phase we had here was to look at a systematic review of actually adapted interventions. So as I say, these were adapted interventions for our 3 populations of interest and for the 3 health promotion topics that I mentioned. Our third phase was to move into undertaking qualitative interviews. And the reason for this is that we really found in previous research that often undertaking a systematic review, the evidence that we found was lacking because it had been constrained a bit by what people had been able to put into their research papers. So there was often a lot of evidence or actual additional information that the researchers weren't able to publicize. And so we wanted to try and tap into their experiences and do this through qualitative interviews. And the last phase was just the synthesis, trying to bring together these 3 components. And we undertook a sort of realist synthesis for this, trying to look at not just what worked in terms of adapting interventions, but what worked in different contexts and why. So I'll talk through each phase as I go, and do please bring up any questions as I go along. So phase 1 was really a very high-level research, as I say, looking at high-level guidelines and systematic reviews. So I've listed here the different databases that we looked at. What we did is we identified initially 15 UK guidelines and also 111 systematic reviews of relevance to these populations and these health topics. And what we did with these was we wanted to scrutinise them to see what evidence there was for consideration of ethnic minority populations. And so we looked at all these guidelines and reviews and search them for terms relating to ethnicity. So I've just listed here, so I just use my pointer, just listed here the different terms. Oh, sorry, I'm not managing to get that to work, but the different terms here that we looked for are highlighted, such as ethnic, racial, minority, to try and find if there had been any mention of these populations. And what we found is within this body of evidence, there were 5 main themes that emerged. The first was really that there was an acknowledgement of a diversity of populations, and there was acknowledgement or an identification that there were evidence gaps relating to these populations. Thirdly, there was an observation that there were definitely differential effects of interventions for different populations according to their ethnicity. And there was a proposal that the adaptation of interventions might help. However, there was no actual recommendations given in any of this literature as to how you might go about adapting your interventions, and this is where we found the big gap to be. There was, however, suggestions that we should work on improving research design, analysis and reporting, and able to generate some evidence around this theme of this area. So really this phase 1 actually just supported our rationale for our study. It made us sure that there was a gap in terms of the evidence we were looking for, and that there was really a good rationale for looking more in depth at the literature on interventions that had actually been adapted. And so we move on to phase 2. Phase 2 was a systematic review of actually adapted interventions. So as I say, this was looking at the literature worldwide of interventions for African, South Asian and Chinese origin populations that were for smoking cessation, physical activity and healthy eating. So we searched all the databases listed at the top, and we found over 48,000 potentially eligible studies, so a big body of literature. But once we reviewed these, we found that there were 7 systematic reviews that were relevant, and also 107 studies published in 154 papers that were of adapted interventions and that were relevant to these topics. You can see from the map at the bottom that there was definitely a preponderance of research within the United States. So from all the literature that we found, there were 104 studies that had come out of the United States. There were 7 that emerged from Europe, and then just 3 from Australasia, 1 from Australia and 2 from New Zealand. So really a big preponderance of the research was from the United States. So I'll just talk a little about the systematic reviews and the evidence that we found in the individual studies of adapted interventions. So focusing first on the systematic reviews, what we found was that there were 7 systematic reviews of interest, and actually again the majority of these were from the United States, and as you can see they were focusing on African American populations. Also, the majority of these systematic reviews had a narrative synthesis, with only 2 here at the bottom of this point, which actually were able to have enough evidence to undertake any kind of meta-analysis. We found on the whole that actually the evidence was inconclusive. So from all these systematic reviews at the top 5 were all inconclusive in trying to see whether adapted interventions were more effective than unadapted or not. And then there were only 2, although these were actually the meta-analyses, that showed some beneficial effect of the cultural adaptation on the effectiveness of the intervention. So the top one showed that the cultural specific or the adapted interventions were more effective in the short term. However, they didn't have any evidence for this in the long term. And the second one at the bottom showed that there was a significant effect observed for the adapted interventions over the unadapted interventions. However, this was only for some of the outcome measures. So really, there was still very little evidence after looking at the systematic reviews. So we then went on to look more specifically at what we called the head-to-head studies. So as I said, from looking at individual studies of adapted interventions, we actually had found 107 spread worldwide. However, most of these studies we found actually didn't compare an adapted study with an unadapted study. So this is where it gets slightly difficult to explain. So what we were looking for ideally was a study that was conducted with one population and they had 2 different studies compared. So ideally a randomized control trial where one arm was an intervention which hadn't been adapted in any way for the population, and where the other arm was a behaviour change intervention, exactly the same intervention, but which had been adapted for the ethnic minority population. The reason for looking for these in particular was that these were the only ones where we really felt that any difference in effectiveness could be attributed specifically to the adaptation. Because in any other type of study design, you wouldn't know whether the effectiveness was due to the adaptation or not. So what we found is a big bulk of the literature was actually looking at adapted studies and just reporting on whether they were effective or not, but it didn't compare them with the same study that had been unadapted. So out of our 107, we found that there were only actually 8 what we called head-to-head studies, which specifically compared the unadapted with the adapted version. So again, I'll just go through these, and we again found that by far the majority of these studies were conducted within the United States and with African American populations. So there was actually 7 of the 8 studies. There was a variety of health topics, so it covered smoking cessation, healthy eating, and also combined healthy eating and physical activity. The major finding from all these studies was that the adaptation of the studies did seem to enhance their acceptability. And now this finding was something that was also reflected in the whole body of 107 studies that we looked at. So we found that the adaptation really did seem to result in a high degree of acceptability. However, when we came to actually move on to look at effectiveness, we found that there was again very mixed and inconclusive evidence from this body of research. So we found, if we just look down, just right at the bottom, so we only found there was actually 1 study from these 8 studies that showed that the adaptation had actually improved the effectiveness of the intervention. And again, for this study, it was only even for 1 variable. So the adaptation improved the effectiveness of fruit intake within the study, but actually no advantage was shown for weight loss. So it was very little evidence. We also found 3 studies So there's 2 here, and then the one at the top, where there didn't show to be any advantage of the adapted over the unadapted intervention. And then the last 4 studies, which are in the middle here, we found were actually more complex in what they showed. So there were a lot more complex sort of contextual aspects to these. So we found that one of them, the one where I'm pointing just now, showed that there was only increased effectiveness of the intervention when the cultural adaptation or the adaptation was combined with a very strong behavioral component that was put into the intervention. And when it wasn't combined with that, there wasn't actually any advantage. And these 3 here were even more complex. So within these research studies, the researchers had actually stratified their participants into different groups, and they had done this by measures of ethnic identity or cultural affiliation. So they'd undertaken questionnaires where people answered questions that thereby separated them into different groups of cultural affiliation or ethnic identity, and then they aligned this with the effectiveness of the intervention. And so they found that the intervention effectiveness related to the degrees of people's ethnic identity. And it was interesting, it was not always in the direction that you might have imagined. So sometimes the adaptive intervention was more effective when people had a high degree of ethnic identity, but this wasn't always the case. So it was quite a complex relationship that was demonstrated here. So I'll just summarize briefly our findings from this phase of the systematic reviews. So we found overall that there was really increased acceptability, both from our larger body of work and also from these specific head-to-head studies. However, we found that there was very mixed and inconclusive evidence of effectiveness, with quite a complex pattern emerging. And we found, I haven't touched on this previously, but we were also looking for evidence of cost effectiveness, but really the research in this field hasn't moved to that extent yet, and so there was no evidence that we could find of cost effectiveness at all. So it really highlights the complexities of study in this field. Some of the complexities are really the lack of head-to-head studies that we have, and also sort of the poor reporting. So we found that within these studies there was actually quite poor and varied reporting of the adaptations. So people would describe things in very different ways, and we found it hard to actually pull this together. We also found that there was also quite a lot of contextual effects that complicated it. So for example, for researchers, it made it quite difficult, for example, the setting of their intervention. So we found that sometimes people were trying to compare an adapted with an unadapted intervention, but obviously both of these interventions were occurring within the one population group, that they were randomized to either intervention. However, both these groups, whether they were adapted or not, were conducted within an environment which was composed of one ethnic minority, and they find that this had actually beneficial effects of its own, so that their control group, which they were trying to look at of being unadapted, actually had some benefits just from being composed of one ethnic minority group. So there was kind of effects of the group composition itself, and so it was difficult almost to maintain the control conditions. They also had difficulty maintaining control conditions sometimes because just of very close-knit communities, where there was sometimes contamination and sharing of the intervention, particularly if there was a good intervention in place, it often got shared between other groups, and so it was hard for them to maintain sort of strict randomized controlled trial conditions. And so there was a lot of complexity within these studies. And as I say, the complexities that I mentioned before, according to the sort of variations of effectiveness, according to different levels of ethnic identity, which in some studies weren't even investigated, but in others were. So we were able to see that really this field is quite a complex field and actually still quite early in development in terms of its research. What we were able to do in a sort of practical way is, although we weren't able to find evidence particularly of effectiveness, what we did is we went through all these studies and we extracted all the examples we could find of different approaches to adaptation, just to try and come up with all the different examples of what people have tried to do. And I'll refer back to this a bit later in the presentation. So I'm just moving on now to phase 3. So phase 3 of our research was, as I say, the qualitative interviews. This is particularly Jingjing Lu's area of expertise. So if there are specific questions that arise, I may want to pass them on to Jingjing. I'll see how I can do. I'll try and represent this to the best of my ability. But what we did is we undertook interviews with 26 international experts in the field and practitioners as well, health promotion practitioners. Some of these experts were identified through the research papers from the previous phases of our research, and others through sort of snowballing and contacts of different people that we'd contacted. The interviews were recorded and transcribed and thematically analysed. And I'm just going to highlight some of the findings that we have. The findings really helped us to understand, I guess, more the processes and experiences of developing and conducting these interventions. So from our papers, we had some of the actual hard outcomes, but we wanted to understand kind of the processes and experiences that people were encountering as they were trying to undertake adaptation, and as they were actually delivering the interventions, and what they were finding were sort of the barriers and challenges to this work. And the findings that we have highlighted were around 3 areas. So one was the intersection of ethnicity and other demographic variables. The second was more looking at sort of representational elements of ethnicity. And the third was looking at the sort of contextual experiences surrounding ethnicity. And so I'll take each of these individually and just discuss these a little bit. So the first area was the intersection of ethnicity and other demographic variables. So what we found in talking with these researchers and practitioners was that often in the research field and also in healthcare facilities, we often consider ethnicity and other factors which may influence health behaviour individually, and we don't look at them together. So for example, things like age or gender, social class, sexual orientation. So we often, partly in collecting these data, but also in thinking about them, we often think about them sort of in silos and individually. However, the reality that came across from our interviews is that there are really more synergistic effects of these variables and kind of cumulative impacts that need to be considered when developing and delivering interventions. So I have a couple of quotes here just to really illustrate what we found. So I'll just talk about this first one here. So this quote was from a smoking cessation intervention that was designed for a Chinese origin population. And what they found here was there was really a strong interaction between ethnicity and gender within this intervention in terms of how it was the best way to deliver the intervention. So often when we're delivering these smoking cessation interventions, there's evidence to support sort of group delivery and the involvement of peers and families in order to support people and help them through this kind of difficult time of becoming smoke-free. But what they'd found with this research was that specifically for Chinese males, that this wasn't the right way to be delivering the intervention at all. So as we see here, it says the Chinese population prefer the men. The men like to become smoke-free and then celebrate it back with their families so that they won't lose face if they relapse. So here it was really important that they could just participate in this intervention by themselves, and then if they became smoke-free, that they could then share it with others, but it wasn't something that they wanted to share in the process. So there was quite an intersection here. Our second example is from a physical activity intervention that was designed for African American women. And here we found that there was a strong intersection between age and ethnicity. So we found they were talking, these women, about the appropriateness of a group instructor that was being selected for the intervention. And we found that actually the ethnic origin of the instructor was as important, well, actually almost more important, was actually the age and kind of experience of this instructor as their ethnic origin. So they were both important things to consider when trying to find someone to deliver the intervention. So what they said was, it is just as important to these women in the focus groups when we started. They said, now don't bring in here as our fitness expert a 20-year-old that weighs 110 pounds and is perky. They don't understand what we're going through with our back problems and our knee problems. And so it was really important to these women that whoever was delivering this intervention was someone that they could relate to, both from the point of view of their ethnicity, but also from their stage in life. So these are both sort of illustrations of the intersections that we found. The second finding that we had was to do with the representational elements of ethnicity. So what we found here is that the targets of adaptation that people choose for interventions often encompass aspects of ethnicity that we're familiar with, such as language or culture or spirituality, and try and tap into these as areas to adapt the interventions. And these things are well known to us, but what the researchers we talked with were expressing was that in reality these things are a lot more complex and nuanced, and that they have to be explored more with your specific population in order to get them right and to make these interventions appropriate. So at the top here, we just have an example of an intervention that was developed for a South Asian population for smoking cessation. And we found that Ramadan is often chosen as a good time to put health interventions into place. And this had been an example that had been chosen for a smoking cessation intervention. But when they evaluated, they found that actually this wasn't appropriate at all. And what people said is that Ramadan was such a busy month that everybody's actually focused on the spiritual aspect of fasting and family life. And you've got Eid, and people will say, well, we'll do it after Ramadan. So it actually turned out that this wasn't really a good focus for delivering the intervention. Our second example here is that often as a target for these interventions, people try and look at the sort of social groups within the community and try and capitalize on close-knit communities in terms of social support and delivering the intervention. But again, this is another example of where this can be more nuanced and actually not always appropriate. And so what we found here was that this was an intervention that was developed for smoking cessation for Bangladeshi populations within Tower Hamlets in London. And what they found is that actually there were confidentiality issues, both within the community in London, but also between the community in London and their ties back in Bangladesh. So what they said is we can't do it in groups, again for confidentiality issues, because if a community is quite close-knit, you have to make sure that they don't, that they're not in the group where someone knows them from Bangladesh back home. So there's a lot of village ties, so they don't really want somebody older. Somebody older wouldn't want somebody younger than them knowing about their personal issues and why they smoke. So this is again just a demonstration of what we would maybe take for granted as a good sort of setting for the intervention, but actually where it's more nuanced and it turned out not to be a good way to deliver it. And also within this quote, we can see again there's some intersections with age in terms of that relationship between older people not wanting younger people to know about their health behaviours. So then the last theme that came up from our interviews were the contextual experiences of ethnicity. So what we found within this was that there was a lot of talk about context, and by this, what we were referring to is several different aspects. So one is sort of the contextual effects of people's past experience of healthcare and healthcare research and how this may influence their engagement or their feelings about future interventions. Another is just the contextual effects of people's social roles and responsibilities. And then a third is really to do with the context actually of social spatial settings of intervention. So it's more a sort of geographical aspect that we may think about in terms of context. And so we were looking really at how these may act as both drivers and barriers to engaging with interventions. So what we found in this first quote here, I just highlight, this quote arises from an intervention that was looking at smoking cessation within New Zealand. And this was at the time when this first smoke-free legislation was passed within New Zealand, which was banning smoking in public places. And what they found in terms of people's sort of social spatial settings was that there were actually whole communities that were completely excluded from these messages. So what they said is we found there was a lot of the communities that weren't accessing mainstream media and they weren't getting these messages across about how to take the smoking outside. And about the fact that it was now, legislated against smoking in public places, bars, restaurants, and things like that. So there was a whole section of the New Zealand population that missed out on the message. And actually, within this quote, they were talking specifically about the Chinese origin population, and particularly within Auckland City, where this population were living within certain areas, often working within exclusively Chinese environments, and also, as they say, not accessing mainstream media, so they were completely being missed from these messages, health promotion messages. And our second quote here is almost the opposite. So this is sort of looking at the other extreme, where the engagement in interventions was affected by the contextual effects of previous involvement and past experience of healthcare research, which meant that people were actually being sort of over involved with these messages and being fatigued. So there's a danger of intervention fatigue, and particularly when you keep turning to the same natural helpers over and over again. So this was talking about often, particularly perhaps within the UK, where we may be working with smaller, particularly in Scotland, working with smaller ethnic minority populations, there's often particular leaders or identifiable people within the community who've been very helpful with developing interventions and who are influential within their communities, but there is a tendency often to turn to these people repeatedly for help, and so these experiences can kind of affect their future engagement with this type of research. Another thing which I actually don't have a quote here for it, but which came up is similarly that people can become fatigued and become a bit wary about interventions if they've previously been involved and then there's been no kind of, say, sustainability. So the researchers that we interviewed talked a lot about sustainability of these adapted interventions. And often what was the case is that these adapted interventions were perhaps developed within a research setting rather than a health service delivery setting. And there was maybe only money for them for a short funding for delivery and evaluation, but no ongoing sustainable funding to actually deliver this on an ongoing basis to the population. And so I think people had a tendency, their involvement um, in these sort of studies had a tendency to cause them to become quite disillusioned, because they maybe would be delivered something that was helpful and very good, but then it would only last 6 months or a year, and then there was nothing ongoing delivered to them. So it made people a bit wary about becoming involved. So these are really the three main lessons that we learned from our qualitative section, and that really complemented the findings from our literature. So I'm just going to talk about now our research synthesis. So we had quite a variety of components involved in our research, and we had to find a way to try and bring this together. And so what we wanted to do was bring together the research that we'd done in terms of literature and bring it together with our qualitative findings, and try and see that we could produce something constructive at the end of it. So we didn't want to just be saying we did this research and actually the evidence is really inconclusive and there's not much that we can advise. We thought there has to be something that we can produce that can be useful from this research. So what we did was we tried to construct a sort of standardized approach to adaptation. So what we had found in the literature and also in talking to researchers was that there was no real concrete foundations for this body of work. There was a lot of different approaches that had been tried in different places, different terminologies, different ways of reporting, and nothing that really brought this together. And so we hope to try and bring it together in some kind of standardized approach. And then we also specifically hope to incorporate some of the qualitative elements which we had found so useful and bring this into the research as well. So I have here just our three phases. So there was the systematic overview, the systematic review, and the qualitative section. And what we did is we brought together the systematic review and the qualitative section, and we tried to create a typology of adaptation approaches and a pathway to adaptation. So this, as I say, was a standardized approach to adaptation. It's similar in a way to other typologies and taxonomies that have been produced. Specifically, there's fairly recently been a taxonomy of approaches to behaviour change techniques, which was created by Susan Mickey and her team. And this broke down behaviour change into a long list of different techniques so that you could try and identify them within interventions and then try and associate which techniques were actually used when people were carrying out research, and which of these techniques were then associated with effective research. And so we wanted to try and take a kind of similar approach, but with adaptation. Then we also wanted to combine all three phases and bring in our high-level findings with our systematic review and our qualitative findings to produce a kind of a decision tool. And the idea with this decision tool was that it would help people select different approaches to adaptation from the typology and decide what might be actually relevant to the interventions and to the communities that they're working with. So I'm just going to touch on our typology first of all. So the typology that we developed actually came up with 46 different approaches to adaptation. And as I say, these were developed both from the 107 studies that we screened of adapted interventions and also from the qualitative interviews. So most of them came up, to be fair, in the research papers, but there were a few added ones from the qualitative studies. There's just an extract of this below where I show some of the 11 adaptations, and then next to each we have an example. But what we found is that the 46 could be broadly grouped under these 6 headings. So these were collaborative working, teamwork, endorsement, materials, messages, and delivery. So these were the different areas that these 46 came under. And what we really hoped is that these 46 approaches would assist researchers and practitioners and be a sort of practical tool that people could use when they're developing interventions. So in the past, there have been quite high-level approaches. So I've just quoted here, for example, Resnico and also Neto et al., who developed approaches to adaptation. Now, Resnico's approach was to do with deep and surface approaches to adaptation, which were two different levels of adaptation that he talked about. And Gina Neto et al. Developed 5 different principles for adaptation. And what we found is that these are very helpful, but at quite a high level. And when we talked with practitioners in the field, they wanted something that they could actually use in their work and think about, I've got to develop an intervention, I'm working with this community, where can I start to try and think of what to do and what can I take to this community to discuss? So I guess our typology kind of sits below these higher level approaches and is to try and assist people on a daily basis. And what we also hope that it would do is try and provide people with a standard approach to reporting. So we found that it was really difficult when we were trying to synthesize these different papers in our systematic review, because as I say, people had reported things in different ways, they'd used different terminology, and sometimes it was hard to know what was being talked about. Some people might call a certain adaptation one thing in their report, and others the same type of adaptation something else. So we thought if there was a way that we could actually standardize reporting, then hopefully people could use this when writing research papers in the future. And this would mean that when people tried to conduct systematic reviews and pull this research together, there'd be a way to actually try and synthesize it. And this would help with providing meta-analysis and providing better evidence of effect. So these are kind of our hopes. I'm going to, at the end of my talk, include some references to our paper, and you can find the full typology of 46 approaches in one of our papers. But I'm also happy for people to email me, and I can send them a copy of this paper if that would be helpful in any way. As a kind of companion to this typology, we also produced what we called a pathway to adaptation. And what this was really to do was that we found that not all of our 46 adaptations were really relevant at every stage of an intervention. So obviously the intervention sort of pathway covers right from the conception and planning right through to dissemination, capacity building, and feeding back into the community. And not all of these 46 were relevant at every stage. So what we did is we tried to just, in this pathway that I've shown you here, divide it up into different stages of the sort of planning process, the implementation, evaluation, dissemination, and then highlight which of the 46 adaptations might be relevant in which areas. So I've just given a few examples of them here. For example, for the conception and planning, it might be important to think about the target population's social values or conduct a formative work. For recruitment, you might want to think about the program utilizing ethically appropriate formal and informal networks. You want to think about reflecting the target's population's preferred method of communication. So just examples under each of these stages. And what we've done in some of our publications is broken our typology up to fit within these different stages of the pathway. And again, we just thought that this might be a practical tool to assist people when they're actually developing interventions. So I'm just going to move on lastly to our reset decision-making tool. So this was kind of the last bit that came up from being developed from our research. And as I say, it's a tool to help people really use the typology and to try and decide which adaptations might be useful to discuss with the communities they're working with them in order to try and prioritize what they might use. And the reset just stands for relevance, relevance, evidence-based, stage of intervention, ethnicity, and trends. And so I'll just briefly talk through these. So relevance is the first thing that actually came up here. And this in some ways refers a bit to the context that your community you're working with are in. So it's looking really at whether is this topic, is the health promotion topic relevant to the target population? Because if not, then there's probably no point in really progressing beyond this stage. So it's thinking about considerations such as, is the topic of sufficient concern that action is required? So it may be, I mean, sometimes the health topic will come from the community itself, which is great. But often we find that the health topic is maybe being prioritized by the health board, by public health, and then being taken to the community. So we want to know if it's of sufficient concern and that it's a priority to them. Otherwise, people won't engage with this. And what we found is that sometimes this is about the health topic overall, and sometimes it's also about the approach that's taken. So for example, one of our researchers talked about how the health topic of changing diet had been approached in different ways, and how some were more relevant than others. So for example, she had worked with an African American population, and initially they'd taken this health topic to the population in terms of looking at weight loss. And there was really a lack of engagement with this overall. And what they found is that by discussing with the community and readdressing this in a different way, they found that what the real issue and that the community were interested in was looking at healthy diet in terms of improving their health overall, preventing chronic disease, preventing diabetes, and looking at these kind of issues. And so sometimes it's not just about the health topic itself, but it's about how you address it and how you bring it to the population, and what is really a priority for them. The other part of this is actually just looking at engaging with communities and whether there's competing priorities for them which would lessen their engagement. And sometimes this can be very immediate concerns for the population. So finding that if the population, particularly we found in the UK with very recent immigrant populations, they may have much more pressing concerns on their mind in terms of immigration issues, in terms of finding work, safety, just catering for their basic needs and getting themselves established, and then actually coming to them with some kind of health promotion intervention actually wasn't a priority for them at that moment. So it's trying to find out what we can do for these populations and what we can help with, and see what's a priority for them before trying to bring some kind of health promotion intervention to them. So this is really looking at relevance. The second part we looked at was evidence-based, and this is really just looking back at our systematic overview and systematic review. So it's really just thinking about what would be the best intervention to look at for this community. And so looking first of all to see if there was any actual interventions which had been trialled in the past which were effective and had been adapted for a similar ethnic minority community. And if not, if there's any evidence of general population interventions which might be applicable and which we might be able to adapt. So just really supplying an evidence base for what we're doing. The next one is looking at the stages of the intervention, and what we found here is that there was three sort of main concerns. So one was looking at what stages need adaptation, so not always every stage needs to be adapted for the different populations. So we found, for example, this may vary by generation or age, so it may be, particularly in the UK we found with South Asian populations, it may be for older generations appropriate to adapt the intervention for language concerns, to look at different diet. But actually for younger, say second, third generation populations, we might not need to adapt these aspects of the intervention. So it's really trying to consider these different aspects and looking at the population. The next was looking at what stages can be adapted. So some things are much more applicable for adaptation than others. So we found, for example, within smoking cessation, a lot of the evidence is pointing to the use of nicotine replacement therapy. And so there's not much you can do to really adapt that kind of an intervention, although you can look at adapting the delivery of the intervention and the other things that surround the NRT. But it's just considering that not everything can really be adapted. And the last one is looking at what stages are able to be adapted. And this is just something that came up from our interviews and looking at the kind of the constraints that researchers are often working under and looking at the kind of real life difficulties they have. So it's looking at there may be constraints from a financial point of view as to what they can do or from capacity of staff. And so they need to look at what they might like to adapt and then sort of prioritize what they are able to actually adapt. So for example, with the intervention we talked about previously for African American women, where they really wanted someone to deliver the intervention who was a female of a particular age and of the appropriate ethnicity. It could be sometimes hard to find someone who has the right working skills and also fits all those criteria. And so sometimes you are constrained a bit by things like finances and also staff capacity. The next part was looking at ethnicity, and so looking at our typology, we might want to think about what elements of ethnicity are most important to consider. Is it the kind of conventional elements we talked about, for example, religion, language, cultural practices, or do we need to think more about the intersections with age and ethnicity? Do we need to think about the representational elements and nuances of these conventional elements? And do we need to think about the context in which these interventions are being delivered? So there's a lot to consider in terms of ethnicity and how we bring this into adapting our interventions. And then lastly, just thinking about the degree of heterogeneity within populations. So we saw from some of the research that they had stratified their populations by degrees of ethnic identity. And so obviously this is something we need to consider when we have a specific community in mind. Do we develop one intervention and will that be appropriate for everyone within that group? Or do we need to think about catering for different degrees of ethnic identity, different cultural practices, different demographics within the community? So just definitely incorporating heterogeneity within our considerations. And the last part was thinking about trends. So what we felt as well is that ethnicity is a very fluid concept, and so also adapting our interventions has to be fluid. We can't just put something in place and then kind of sit back, but we have to think about shifting patterns and trends within health behaviours within the population, and think about when our interventions in place, whether we can monitor these patterns and trends and whether we can adapt them over time to keep them relevant and hopefully effective. So that was our reset tool. So I'm just going to quickly go over our conclusions and recommendations. I realize I'm probably taking more time than I intended, and I want to make sure to leave time for questions. So the key findings that we had was that there were currently a lack of evidence really on this topic. And what we need is more high quality research. So what we specifically need are more research study which look at adapted versus unadapted interventions, which we can really comment on the effectiveness of the adaptation. We need something to help us report the adaptations clearly, and we hope that our typology might help with this. And we need to also consider the complexity of these interventions, for example, the nuances and contextual elements of ethnicity that may make our adaptations more or less salient. So it's very important to take this into consideration. And to assist this, we've developed our 3 tools, which we hope might help in this field. As I say, this work was completed in 2012, and so the tools are still pretty early on, and they will need really more testing and validation. So we now have a couple of studies that have started to be developed using these tools, but we really need a lot more in place to see if they're helpful. And so we'd really appreciate any feedback and thoughts you have, and any feedback from researchers that may be using these tools or attempting to use these tools and what they think about them. My big desire would be to also test some of this looking at the literature for other populations. So I'd really love to look at the literature for adapted interventions for Indigenous populations, for Hispanic populations, and see whether our typology also holds true with the literature from these populations, or whether there's other things that we identify that could be added to the typology as well. So there's still a lot of work to be done in this area. I was just going to conclude with a brief look at some findings from this conference, which I attended at the end of last year. So this took place in Glasgow, and this was held by the European Public Health Association. They actually have a migrant health section which specifically meets, and they had a whole day which was devoted to people presenting and talking about the adaptation of behaviour change interventions. And these are just the conclusions that they came up with, some of which reflect our findings and others which move things forward. So they really commented as well that there needs to be common international definitions of the main concepts regarding ethnicity and the terminology of adaptation. That it's important to document what types of adaptations are being undertaken so that we can look at the effectiveness. And a big point they had was that ineffective programs that aren't effective for the general population should not be adapted. So we really need to look clearly at what we're taking as the base for our adaptation. What we found was that this was easier for smoking cessation than it perhaps is for other health topics. And for example, for healthy eating and physical activity, it's harder to find very concrete evidence for the general population. And therefore that makes it harder to adapt, and also harder to prove effectiveness of the adapted version if we didn't have any proof of effectiveness of the underlying intervention. So that was just something additional to be aware of. There was also very strongly raised from some of the contributors from Europe that we should consider looking at adaptations focused on commonalities across different ethnic minority groups versus looking specifically at individual groups. And this partly arose from some of their constraints in terms of funding and access to developing these kind of interventions. So what they found is that often within their budgets they weren't given much funding to develop these interventions, and so they didn't want to just deal with one ethnic minority group. They wanted to try and develop interventions that perhaps could have commonalities that they could adapt for, that they could then roll out across groups, and that they'd be more able to do this within their budget. So there was a lot of discussion on the day about whether this was appropriate and whether this would be a good approach to go with. They also just mentioned that it was crucial to include cultural and broader diversity competencies within medical and health promotion staff training, just to make people more aware, and that there should really be more effort from government agencies, public and private institutions and organisations to come together and try and develop well-adapted health promotion programmes. So that was just the key findings from that day, which kind of moved things a bit forward and I thought would be helpful to bring to you. So I'm just finishing now with a list of our key publications, and as I say, I'm very happy to send on any copies of publications to anyone that they might be useful to. And would also just be really interested to hear people's thoughts and feedback of our work and how this relates to them. Thank you very much.
Thank you very much, Dr. Davidson. Very important and interesting work. So we'll open the floor now to any questions people have, and I'd like to start with one of my own. So outside of these, recent publications for your toolkit and like the pathway to adaptation, are there currently any materials available about your toolkit that could be used by community leaders or stakeholders who are seeking to do intervention adaptations?
I think, to be honest, the biggest resource we have so far are really our publications that we have that sort of outline the typology and the different stages. We don't have anything developed beyond that. What we have been doing is trying to disseminate locally within the UK to sort of different health organisations and try and put this across to them so they may be able to use it. But unfortunately, we haven't had much in the way of resource to try and disseminate this further.
I see. Well, I'm sure lots of people would look forward to knowing in the future if there's going to be, some sort of website or, downloadable materials to sort of, put this into use in their own local areas.
Actually, that's a great suggestion. I'll take that to the team because it would be fantastic if we could find the resource to do that. I think it would also be great for us because then we could get some kind of instant feedback on how people are finding it too.
Yeah, definitely. I mean, of course, people in your field, would be more than happy to read all of your publications, but, someone who's a county commissioner or perhaps a mental health clinician, they may not have, that type of time, and so something that might be a little more easily digestible for them would be a great resource for those people.
Actually, that's so true. I was going to say, and in particular, the report we produce for our funders is terrible. I wouldn't go near it. It's far too wordy and long. I've been using my copy as a kind of doorstop. So
yes.
So yeah, I think that's a very good point.
Always the challenge of academic researchers. Does anyone else have any questions for Dr. Davidson? I see one from Courtney. What challenges may there be in intervention adaptation between urban and rural communities?
That's interesting. I was thinking that's something we haven't really taken into consideration specifically within our research. I think it is something that came up in terms of the different contexts and how that might affect the adaptation. So very certainly I would think that the type of adaptation you may be looking at within an urban setting may be very different to a rural setting. And the other thing in terms of geography that came up for us was very much looking at how ethnic minority populations were spatially located, particularly within different cities. So what we find is that locally where we live, the ethnic minority populations are actually very spread. They don't tend to live within certain areas. But in contrast, in London and other big cities, there are often very concrete areas where certain ethnic communities tend to live. And so delivery of interventions often has to be looked at in different ways. And I think particularly we're challenged by the communities that are very spread because it's hard to find perhaps particular routes into that community of how we can engage with them. I know often that the rural communities do sometimes tend to get neglected as well, particularly in the UK in terms of bringing these type of programs to them. And also in New Zealand where I was working, this was the case as well. And what we did find is that often the rural communities in New Zealand where there were particularly high congregations of Māori and Indigenous populations, and they were being kind of excluded from these interventions. So it's definitely a really good point to take into consideration.
Yeah, that's certainly the case as well in the United States, that rural areas often get overpassed or overlooked.
It's interesting, yeah. And I'm not sure how we actually address that in terms of sort of health service workforce and how we can bring these kind of interventions into the rural setting.
Yeah, it's certainly a challenge that you know, we've shuffled into the work that we do at CAPE. Um, any other questions for Dr. Davidson before we end the webinar today? Okay, looks like that's it. So as I mentioned before, we will be posting the recording of this webinar on our website, healthbench.info/webinars. In the next couple of days, and so, you know, feel free to access and share with people who might be interested in this topic as well. Thank you so much, Dr. Emma Davidson. It was a very interesting and important topic, and we're looking forward to seeing more about your research in the future.
That's great. Well, thank you so much for having me. And as I say, I'm very happy for anyone to contact me. I'm just realizing I haven't got my email address there, but I don't know, they could probably find me on the University of Edinburgh and find it there. Or maybe through contacting you, but very happy to address any other questions that way.
Yeah, if you don't mind, go ahead and put the email address you prefer to be contacted at in the chat for the people here, and we'll make sure that that information goes on our website as well.
See if I'm doing this correctly. Is that it there? It's emma.davidson, yeah, at ed.ac.uk.
All right, perfect. Well, thank you everyone who attended today, and thank you, Emma.
Thank you.